Hello everyone, welcome back to my channel, and we will start from page number 107 today, and the topic name is recurrent after ulcer. With this topic I do recommend reading Odell after ulcer chapter or the case. Okay, so recurrent after ulcerative disease is the most common cause of non-traumatic ulcers of the oral mucosa. So the most common causes of oral ulcers could be traumatic or the non-traumatic. Okay, so if there is any trauma, then there could be few reasons why there is trauma or that could lead to traumatic oral ulcers, such as any sharp or rough edges, restorations, toothbrushing, appliances, or burns. But the non-ulcerative or non-traumatic form of ulcer is like Aphthous ulcer. And this disease has an immune-mediated pathogenesis and is characterized by the periodic eruption of painful ulceration of the oral mucosa. So this disease is immunity-related. When your immunity goes down, then there is high chances of getting these ulcers, and there is periodic eruption, and they are very painful. After ulcers can occur acutely with smoking cessation as well, but these usually resolve with time or can be triggered by trauma like toothbrushing, appliances. These could also lead to ulcers. To address the causes of oral ulcer, so see page on this one. The ulcers usually occurs on the mucosa of the cheek, which is mainly the non-keratinized mucosa, which is the soft mucosa. These ulcers generally occur on those areas, which are mainly the cheek, lip, floor of the mouth, but can occasionally affect the mucosa of the gingiva and hard palate as well. Three forms of aphthous ulcer are recognized, which are the three forms. First form is the minor aphthous ulcer, then is the major, and then herpetiform ulcer. Okay, so the minor ulcers are the most common form, and they present as smaller lesion, and their size is about 2 to 4 millimeter in diameter. And whenever they happen few at a time, and they generally heals within 2 weeks. So this is not a red flag if they are healing within 10 days or within 2 weeks. Okay. And the other types of ulcer is the major aphthous ulcer. They are less common and they are bit larger in size, which is 10 millimeter or above in diameter. They are only 2 to 4 millimeter in diameter. And these ulcers are larger in size, so they would take longer time to get healed, which would include like around 6 weeks to some months. And healing, whenever there would be any healing, there would be submucosal scarring as well, but here there would be no scar. Then the third form is the herpetiform aphthous ulceration. They are rare. They are rare form, and they present as a recurrent crops of non-vesicular small ulcers. So they are very small. They are even smaller than minor aphthous ulcer. These are 2 to 4 millimeter. They are only 1 to 2 millimeter in diameter. And what they do is these pinpoint smaller size ulcers, they coalesce with each other and forms a large ulcer, and they usually heal within 1 to 2 weeks and not caused by herpes virus, so do not have a cluster pattern. Okay, so assessment of aphthous ulcers involves taking. How would you assess the aphthous ulcer? First, you need to take the thorough history, and then you need to do the thorough examination. And also, you need to look for any red flag feature. Which were the red flag feature for the ulcer? Ulcer persisting more than 2 weeks, ulcer at the high risk side, recurrent ulcers, or ulcer in non-traumatic ulcers in the children. Okay, so in children, investigate for systemic cause of non-traumatic ulceration, and in adults who have an additional symptoms, then investigate for a systemic cause. What could be the systemic cause that could lead to aphthous ulcer? Which are deficiencies, mainly iron, vitamin B12, folate or zinc deficiencies, or celiac disease, ulcerative colitis, Behçet syndrome, PFPA, which is periodic fever, after stomatitis, pharyngitis, cervical adenitis syndrome in children. And you will read all these points in detail in Odell case. Deficiency should be treated only on laboratory confirmation. So you should not be even the if suppose if patient comes to you and she has after ulcers, so if you ask her like, did you got any blood test done, or do you have any deficiencies? She said, I don't know, it might be the case. So you should not start prescribing her any these iron or vitamins. You should first get the laboratory confirmation, only then you need to prescribe, or you can advise your patient to take the vitamins or the whatever it is. Okay. Then management of recurrent aphthous ulcerative disease. If an aphthous like ulcer occurs in a children, then what you need to do is referral to for further investigation, because it could be a sign of systemic disease. Then for management of aphthous ulcers in patient receiving palliative care. Palliative care is mainly the patient who is in hospital. Then you need to see the management advice in ETG. Okay, but that is not for dentist point of view. That is mainly medical point of view. Okay, but if there is any topical corticosteroid treatment can produce rapid healing of minor aphthous ulcer, particularly if used in the prodromal or pre-ulcerative stage. Okay, so topical corticosteroid, which type of corticosteroid? Hydrocortisone 1% cream or ointment. You can advise your patient to use this cream mainly if they apply it in the prodromal or the pre-ulcerative stage where the ulcer has not formed yet. Then the healing would be rapid. The aim is to treat the lesion rather than, and but this cannot prevent these things to be happening. So what would be the prevention? What prevention you can advise for the patient to avoid after ulcer is the um, get them evaluated and get their tests done to find out what's actually the cause which is causing the ulcers in the patient's mouth. Okay, and you need to advise like to the patient that apply hydrocortisone 1% cream or ointment topically to the lesion 2 to 3 times daily after meals. If pain relief is required for minor aphthous ulcers in adult, apply a topical anesthetic. So if the patient is so this corticosteroid cream help in healing. Okay, this does not really help much with the pain. So if any pain relief is required, then you will give the NSAID. Which NSAID gel you can prescribe to your patient is the benzidamine 1% gel. You need to ask your patient to apply it topically 2 to 3 hourly as necessary. Okay. And there is one other option that you can advise, which is the lidocaine viscous solution. It is an alternative but it is mainly used in hospital setting and it has higher cost. And if you need to advise this lidocaine viscous solution, then the concentration is 2% and use the lowest dose necessity up to 15 milliliter. Rinse in the mouth for 30 seconds and then spat out 3 hourly as necessary, maximum 8 doses in 24 hours. Ulcers that are not improving after 2 weeks are potentially malignant. So this is a sign of red flag. This is a red flag sign, which is if the ulcers who are not improving even after 2 weeks. So what you need to do is refer the patient to the specialist and advise him to get the biopsy done and for the further management. And also, if the patient has minor aphthous ulcer, then you can still try to treat it or still try to help the patient either with the hydrocortisone cream or with the benzidamine 1% gel. But if your patient has major or herpetiform ulcer, then or in immunocompromised patient with neutropenic ulceration, for all those patients you need to seek specialist advice. So in short, you are only treating the minor aphthous ulcer with these two creams. Okay, and you need to find out what's the cause of the aphthous ulcer in your patient's mouth. Then oral mucocutaneous herpes, primary oral mucocutaneous herpes, primary oral mucocutaneous herpes simplex virus infection is also called as herpetic gingivostomatitis. It occurs mainly in childhood with fever, with painful intraoral lesions, systemic symptoms such as there would be malaise, the patient would be lethargic, and there would be the cervical lymphadenopathy. Okay, so these are all the signs. And one more thing, for the herpes simplex virus also, there is a case in Odell. You can read about it and you will get more insights. Okay, intraoral herpes simplex virus infection virus lesions begin as blisters and ulcerate rapidly. Okay, so they start as blisters and soon they ulcerate. Healing occurs within several days in infants but can take up to 2 weeks in older children. During this time, it may be difficult to eat and drink because they have lesions in their mouth. There are vesicles which has now erupted and now there are ulcers in the mouth. So there would be problem in eating and drinking, and sometimes hospital admission may be required because there is painful intraoral lesions, systemic symptoms as well, and even the cervical lymphadenopathy. Okay, so herpetic gingivostomatitis is rare in adult, but it is common in children. Okay, but can be severe and present with dehydration due to severe odynophagia. Then, while herpes simplex virus is the most common virus to cause mouth ulcers, other viruses, example varicella zoster virus, Coxsackie virus, or cytomegalovirus, may be the cause. Okay, so although herpes simplex virus is the major cause, is a major cause to cause the mouth ulcer, but there are certain other viruses as well. And intraoral herpes simplex virus lesion may resemble those seen in necrotizing gingivitis. This thing we have also read in the necrotizing ulcerative gingivitis topic. There they mentioned that do not confuse this lesion with the herpetic gingivostomatitis because they would look bit similar due to their painful lesions. But how you can differentiate them is the necrotizing ulcerative gingivitis generally occurs in young adult smokers, and this disease generally affect the interdental papilla. Okay, but this herpes simplex virus generally happens in children, and there is overall and a more widespread presentation of herpes simplex virus. Okay, then and is confined to the gingival tissue, while herpetic gingivostomatitis lesions are widespread and affect all soft tissues in the mouth. Okay. Then to reduce the risk of virus transmission, advise patient with an active herpes simplex virus infection to avoid direct contact of the lesion with other people. Okay, so as this is viral lesion, so it can cause the transmission. So what you need to do is you need to advise your patient to avoid direct contact with the lesion, and treat minor primary oral mucocutaneous herpes with supportive management. Which is the supportive management? Oral fluids to fight with the dehydration, antipyretics because the patient has fever, analgesia because patient is in pain, and apply a topical anesthetic or analgesics. So which is the gel that you have that you can prescribe to the patient if they have painful lesion is the benzidamine 1% gel, and this should be prescribed to the adult and child who is older than 6 years, and applied topically 2 to 3 hourly as necessary. If this is not available, lidocaine viscous solution is an alternative topical anesthetic for hospital settings. And you can learn the doses. This option, which is a lidocaine viscous solution, this is generally done in hospital setting, so would not be you can just have a read about it, like in what dose we can use in adult, what dose we can use in 3 year or older or younger than 3 year older, but would not be very very important as exam point of view. Okay. And if the pharynx is affected in adults and children older than 12 years, then lidocaine, this solution, they can gargle it and swallow it. So that can help with the pharynx. And management of primary oral mucocutaneous herpes differs for the following patient. So whenever the patient comes to you with the primary oral mucocutaneous herpes presentation, then what you need to do the management is this one: oral fluid, antipyretics, analgesics, and benzidamine 1% gel, and ask them to avoid the direct contact. Okay, but for these patients, you need to refer them straight away to the medical practitioner. Which are these patients? If the patient has very severe presentation, if the patient is immunocompromised, or if the patient is HIV positive. Okay. Then recurrent oral mucocutaneous herpes. So there are two phases, like this primary oral mucocutaneous, this virus, this is a viral infection which firstly when it happen as primary, it is more widespread, and later what it does is it just go and sleep in the body or sleep in the cells, and later if there is any incidence or any stimulant happen, then it can cause a recurrent infection, which is the recurrent oral mucocutaneous herpes simplex virus infection. It follows latent reactivation of the virus. Lesions usually occur on the lips, simplex labialis, or cold sore, but can also occur on the intraoral mucosa or other areas of skin as well. Okay. Lesions are usually preceded by the prodromal stage, which would what is the prodromal stage? That there would be some several hours to days of the symptoms of pain, burning, tingling, or itching sensations, and recurrences are usually mild and infrequent, and their frequency can be minimized with skin protection. Okay, herpes simplex virus reactivation may be complicated by if there is any erythema multiforme infection on top of that, so that can get more complicated. A herpes simplex virus lesion affecting the oral mucosa cannot be differentiated from an aphthous or traumatic ulcer. Usually, using microbiological testing, most adults will have positive serology for the herpes simplex virus from the previous exposure, and viral DNA may be detected on the swabs of the aphthous or traumatic ulcer. Instead, diagnosis requires a thorough history and clinical examination. So here they have just mentioned, like even it is very hard to differentiate them either from the aphthous or traumatic ulcer, and they also shows positive serology. It is mainly caused by the primary infection, the previous infection, which is the primary infection happened in the body. So from that infection also, when you do the serology test, they would show positive HSV serology, and the diagnosis should be made through a thorough history and clinical examination. To reduce the risk of virus transmission, advise patient with an active herpes virus infection to avoid direct contact of the lesion and the other people with the other people. Okay. For a minor recurrence of oral mucocutaneous herpes, episodic antiviral therapy can may reduce its duration. So what antiviral therapy you can prescribe to your patient is acyclovir 5% cream topically 5 times daily 4-5 days. Like just try to remember by the term 5% cream 5 times daily for 5 days, started at the first sign of recurrence or during the prodromal stage. What would be the prodromal stage? Where the patient would feel pain, burning, tingling, or itching sensation. Or there is another option available. This is the cream that you can ask your patient to apply on the lesion, or you can also prescribe this femcyclovir 150 sorry 1500 milligram orally, a single dose, and this should be taken at the first sign of recurrence or during the prodromal stage. Using acyclovir cream for longer than recommended has no benefit, and management of recurrent oral mucocutaneous herpes differs for the following patient. So, for these patient, management would be different, same as like primary one. So, you can treat the normal primary or not so complicated primary lesions, but for and same is for the recurrent thing, but you need to seek referral to medical practitioner or their GP in patient with severe recurrence of herpes, or if the patient has generalized or chronic herpes infection, or if the patient is immunocompromised, and or the patient with HIV. So these 3 points are similar to the primary herpes, with the severe presentation, immunocompromised, and with the HIV. So the only point which is different is patients with generalized or chronic herpes infection. Then mucous membrane pemphigoid. It is an uncommon autoimmune vesiculobullous disorder. You know the vesiculobullous disorders, right? So pemphigus, pemphigoid. So these are the things that affect stratified squamous epithelium. So they does cause a split between the epithelium. So in pemphigus, the I'm so sorry. In pemphigus, the split does happen within the epithelium. In pemphigoid, the split happens below the epithelium. So what it does is it makes the vesicles, and that can lead to these lesions. It occurs predominantly on the gingiva and palate. Mucous membrane pemphigoid presents as large, painful, and persistent erosions and is characterized by subepithelial splitting. So for the pemphigus, it is intraepithelial, and for the pemphigoid, it is subepithelial splitting with bulla or vesicle formation. The lesions heal with variable amount of scarring, and differential diagnosis include pemphigus vulgaris. Refer patient with suspected mucous membrane pemphigoid to an appropriate specialist for biopsy and definitive diagnosis. Management usually requires long-term use of immunosuppressive therapy, and ophthalmologist review is necessary because there is a risk of blindness with mucous membrane pemphigoid. Okay, so mucous membrane pemphigoid, you are not doing anything for this patient. You can just diagnose it and refer her to specialist. For the recurrent oral mucocutaneous herpes, you can treat him if the sign and symptoms are not very severe, but if there is severe presentation or the patient is immunocompromised or HIV positive or the chronic herpes infection, then you need to refer him. Same with the primary one. Okay, and for the after ulcer also, the minor ulcer you can treat, but the major and herpetiform, and if the minor ulcer is not improving within 2 weeks, then also you need to seek a referral. Okay, and tomorrow we will start the candidiasis topic. Alright guys, thank you so much for watching my video, and please do like, share and subscribe. It is very important for me